Good evening, everybody. Welcome back to Journal Club. Today we will discuss the role of the drug-coated balloon in multivessel coronary artery disease. The presenter of today is Juan Pablo Sánchez-Luna from Valladolid in Spain, and we will have the pleasure to have as expert Professor Ignacio Amat Santos from the same institution. So please, Juan Pablo, over to you.
Okay.
Sorry, I will stop sharing my screen.
Sure. Can you see it? Can you see the screen?
Yes.
Well, first of all, good evening, everyone, and thank you for the invitation. It's a real pleasure being here with you. So without further ado, I will start with the presentation of the article. So the article that we're going to review today, it's a recently published paper that was published in JACC, Cardiovascular Interventions. And as you said before, it's about the clinical impact of the drug-coated balloon-based percutaneous coronary interventions in patients with multivessel coronary artery disease. As a background to this article, we have that the length of the number of stents are known to independently predict both in-stent restenosis and thrombosis of the stent, even in the new era of the new generation of drug-eluting stents. The stent implantation, as we know, it may impair the restoration of the vasomotion in stented segments of the artery and those promoting the accelerated neoatherosclerosis. The Grand DES registry, which stands for the Korean Nationwide Multicenter Pool Registry of Drug-Eluting Stents Registry, demonstrated that the multivessel disease, multiple stenting, and long stent length were significant predictors for ischemic clinical events in patients undergoing PCI. In previous studies, drug-coated balloon treatment has been associated with non-inferior clinical outcomes compared with DES implantations in patients with in-stent restenosis and de novo small vessel disease. And as well, the International Consensus Group and Asian Pacific Consensus Group reported that the DCB-only approach in native lesions is feasible and may safely replace this DES implantation if revascularization using predilatation balloon angioplasty is achieved with favorable results. As the hypothesis of this article, it is because as it does not leave any of the lesion behind, the DCB strategy reduces the risk of stent-associated maladaptive biologic response, which is responsible for the restenosis and the thrombosis of the stent, thus promoting vessel healing. Using DCB or alone or in combination with the DES as part of an hybrid procedure to reduce stent burden, which may be reducing the stent length or the number of stents, may be an alternative and useful treatment approach for multivessel disease. The objective of this study was to report the data and the clinical outcomes of patients who underwent treatment with DCB or alone or in combination with DES for multivessel coronary artery disease, and then compare these findings with those propensity matched patients who were treated with DES only from the PTRG-DS consortium, which stands for platelet function and genotype related long-term prognosis in DES-treated patients with coronary artery disease. About the methods of the article, where the populations were 254 patients with successful PCI for multivessel coronary artery disease using DCBs alone or in combination with the drug-eluting stents hybrid approach, were retrospectively enrolled from 3 teaching hospitals in South Korea, which had the experience in treating patients with multivessel coronary artery disease using drug-coated balloons. The hospitals were the Ulsan University Hospital, the Ulsan Medical Center, and the Korea University Ansan hospitals. The eligible patients were those who had lesions of equal or more than 50% and whom the investigator considered to require PCI for at least 2 major epicardial coronary lesions. The patients were excluded if they had previously undergone CABG, if they presented with cardiogenic shock, if they had received thrombolysis before the PCI, or they had single vessel disease or suboptimal or failed PCI for target lesions, or were or were lost to follow-up. The population, the results of the hybrid approach in these patients were compared with those among 2,054 propensity match patients from the PTRGDS consortium who were treated with drug-eluting stents only. This consortium combined 9 prospective registries from 32 Korean academic centers, contributing data from 13,160 patients with DES treated between July 2003 and August 2019, among a total of 13,160 PTRGDS consortium patients. 11,226 patients received the second generation DES, and among them, 4,460 patients underwent multivessel DES implantations. The propensity score matching was performed for 4,427 patients, excluding 33 patients who had a previous CABG. The procedure in the DCB-based group, all the patients were treated with aspirin 2,000 milligrams, and then with Plavix 300 or 600 milligrams as loading doses, then followed by 100 units of kilo of fraction heparin to maintain an ACT above 2,050 seconds during the procedure. Then intracoronary nitroglycerin was administered before the diagnostic coronary angiography, and for the patients with multivessel disease, the PCI target lesions were first determined, and then the balloon angioplasty was performed to determine whether the DCB treatment would be possible. For the DCB-based treatment group, the intervention was performed according to the international and the Asia-Pacific consensus recommendation for DCB treatment, which basically are 5 points. First one, it should be performed the mandatory pre-dilatation with a plain balloon, with a balloon to vessel ratio of 0.8 to 1. Then, after the pre-dilation, the stenting was deferred in all types of dissections from A to E if there was a TIMI flow 3. In the cases of the flow limiting dissection after the pre-dilatation, with having a TIMI flow less than 3 and more than 30% of a visual residual stenosis, the PCI with stent was recommended without the use of a DCB. Then the DCB was inflated to its nominal pressure for at least 60 seconds, taking care to extend the DCB at least 2 millimeters beyond the pre-dilatation balloon length. And then finally, after the DCB use, the final assessment was done at least 5 minutes after administering a bolus of intracoronary vasodilator to prevent any remaining acute vessel closure. All the DCBs were coated with paclitaxel combined with iopramide as a carrier of the drug. That is the second place from B. Brown. The clinical follow-up and endpoints were all the 508 patients underwent clinical follow-up following the index procedure via telephonic interviews or outpatient clinic visits. The study endpoint was a cumulative MACE, which was a composite of cardiac death, myocardial infarction, stroke, probable or definite stent thrombosis, target vessel revascularization, and major bleeding at 2 years. The statistical analysis, basically the clinical characteristics were reported as percentage for categorical variables and mean standard deviation for continuous variables. The comparisons between the groups were made using either the Pearson chi-square test or the Fisher exact test for categorical variables and the student t-test for continuous variables as appropriate. In the comparison of the clinical outcomes between groups, the cumulative incidence of MACE and the other outcomes were estimated using the Kaplan-Meier method, and the groups were compared using the log-rank test. To reduce the effect of the potential confounding factors, the propensity score matching was used to adjust for differences in baseline characteristic, and the propensity score was estimated using logistic regression by considering demographic and clinical variables. In the results, we have that the mean age of the patients was 63.5 years, and the majority of the patients were men. Regarding clinical presentation, stable angina was more prevalent in the DS-only group, while unstable angina was more prevalent in the DCB-based group. In the DCB-based group, 34.3% of the patients were treated with DCB alone, and 65.7% were treated with the hybrid approach using a DES. As we can see in the graphics, the total number of treated vessels and the total numbers of the devices were comparable between the two groups. There was a statistically significant difference in the number of DCBs and the DES used in both groups. And in the DCB base group, the total number of devices used was 2.6 plus minus 0.9, of which number of DCB was 1.7 plus minus 0.8, and the DES was 0.9 plus minus 0.8. The total number of the DES used in the DES only group was the same as that in the DCB base group. Then the mean device diameters were comparables in both groups. The total device length was also similar at 65.2 plus minus 25.4 millimeters in the DCB base group, and then 64.2 plus minus 30.1 millimeters in the DES only group. And in the DCB base group, the total DCB length was 42 plus minus 23.7 millimeters, and the mean DCB diameter was 2.6 plus minus 0.3 millimeters. In the DCB base group, a small DCB with a diameter of less than 2.5 millimeters was used in 36% of the patients. As we can see, here is a summary of all the evidence of all the results that we got in here. So basically, the total lengths and the mean diameters of the DEEs used in the two groups were significantly different. The total DES length was 23.3 plus minus 23 millimeters in the DCB base group, and it was 63.2 plus minus 30 millimeters in the DES only group. The mean DES diameter was 3.2 plus minus 0.5 millimeters in the DCB base group, while it was 2.8 plus minus 0.4 millimeters in the DES only group. There was a significant difference between the two groups when the mean DES diameter was less than 2.5 millimeters, and the number of stents and the total stent length were significantly reduced, both in the DCB base group compared with those in the DES only group. And about the clinical outcomes, there was, in the DCB base group, they had a lower risk for MACE than the DES only group at the 2-year follow-up. The cardiac death was higher in the DES only group, and there was major bleeding was more prevalent in the DES only group. And there was no myocardial infarction, no stroke, or stent thrombosis that was observed in the DCB-based treatment group. Here is the curves, and as we can see in the 2-year follow-up, there was a significant difference between the two groups. And as conclusions, we have that the DCB-based treatment approach showed a significantly reduced stent burden in multivessel PCI, which led to a decrease in MACE at 2 years post-procedure. Then the findings of this study concretize existing evidence that using the DCB safely reduces stent burden in multivessel coronary artery disease, and it may improve long-term outcomes that may be expected by reducing stent-related events. Nonetheless, the role of the DCBs in these settings should be assessed in a prospective randomized control trials. So thank you very much for your attention.
Thank you very much, Juan Pablo. So, and congratulations for this presentation. So, Professor Amat Santos, please, if you want to share with us your thoughts about the paper and in general about the topic of DCB.
So there is a very nice accompanying editorial that was quite positive with the results. So I'm going to be less positive to find out the weak points of the article, which on the other side is very nice to analyze the safety long term of the DCB. This was very useful, but for efficacy, I think there are several limitations. So the first one is that it's a retrospective analysis. They perform some statistical extensive sensitivity analysis to correct these baseline differences. But since it's retrospective, there is a selection bias. So the longest lesions, maybe the more calcified ones, the ugly lesions, probably were treated with DES, drug-eluting stents. This is a factor against the results of drug-eluting stents. Then the first finding is higher rate of MACE with the stents. But this higher rate of MACE is not related to the use of physiology, which was the rate of physiology. Did they use physiology to select the stent length? This is an important factor that we already know for outcomes, mainly in these populations, because those treated with the stent had a higher rate of stable angina. In a stable angina, the benefit is more limited. We have the ischemia trial, and also if we don't have FFR, maybe the authors will report later, but I could not find in supplemental material, then there is a limitation with the strategy selected for the stent. Also, we will discuss later, what about physiology with drug-coated balloon? We don't have much an idea of what is the target when we use drug-coated balloon. We don't target for a very high FFR. What will happen with FFR at 3 months? But anyway, selecting the length of the stent and where to treat and where not to treat, FFR is crucial when we don't address this information. And the third point that I want to highlight, there is higher rate of bleeding events in the stents group. Why is that? Which was the dual antiplatelet therapy? The authors describe what they do per protocol, but this is retrospective. What are the actual data on duration of dual antiplatelet therapy in one group and the other group? Because this might have conditioned the rate of bleeding higher in the stent group. So also we don't have very clear what is the duration optimal in DCB of dual antiplatelet therapy. So these are my 3 aspects to discuss. This retrospective nature, the higher rate of MACE may be related to physiology, and the higher rate of bleeding may be related to the duration of the dual antiplatelet therapy. I don't know what you think.
I thought the same point when I read this article. But my further question is, which is the strength of this article? What do you think? Because as Juan Pablo described, there is one slide which is crucial, I think, and is the one in which they describe the diameter of the stent and the diameter of the vessel, and there was a significant difference between the DES and the DCB. Means that probably the use of this article highlights what we already do in our practice. The fact that the stent in small vessel maybe can give better results than DCB, and this is what I think. But I don't know, what do you think about that?
Yeah, so we tend to underestimate diameters, especially if there is a severe lesion. The most severe lesion is a CTO. If we have a CTO, we always know that the distal vessel is spastic to maintain the perfusion pressure. So if we just see the angio and implant the stent adjusted to the angio, we will be underestimating. With drug-coated balloon, this will not happen because the remodeling of the artery will adapt up to. So this is a very positive factor, but also suggests that we need the information for these patients on intracoronary techniques. I talked before about FFR, but what about imaging? Was it used? How were the sizes selected? Only based on angio? So this is something related to the optimal way of performing PCI. I know the authors of this paper are really, really good, but this information is missing in the manuscript. Anyway, the good remodeling of the vessel is one important aspect. I like very much DCBs in CTOs, in the distal vessel, as I mentioned, but why only in CTOs? In this kind of multivessel disease, probably can have the same effect on not impairing the sizing of the selected tool.
And what about your clinical practice? How do you perform PCI with DCB? Which are your steps? What do you do?
So it depends on the indication. If this is, well, let's say 3 scenarios: multivessel disease, small vessel, or stenosis. For multivessel disease, we have to target the size of the vessel, try to perform this 60-second, maybe pre-dilation, and then 60-second dilation with the balloon. So not being very aggressive, just making sure that we cover completely the lesion and a few millimeters beyond the lesion with the balloon. And we don't pay too much attention to the result because it's common to find some dissection, but we know that this dissection, even if they are relatively large, help the drug to penetrate the vessel's wall. So if the TIMI flow is acceptable, we don't care for dissection. If this is a small vessel, then sometimes we really need to, the indication is very similar, but we should not overexpand too much. We have to be careful with that, because if we have a distal dissection of the vessel, especially if we have treated proximally with long stents, we can increase the rate of thrombosis. So be more gentle, maybe sizing 0.8 instead of 1-to-1 relationship. And finally, in stent restenosis, there we have to be more aggressive. We have to use cutting balloons, then a high pressure balloon before the drug-coated balloon, and then the drug-coated balloon.
Thank you. Very brilliant explanation. Thank you very much. Very brilliant. So we have some question from the audience, from Pierluigi. Which are the real limits of DCB in your opinion?
I think it's all limitations right now, because the evidence is still weak, although positive. There are a lot of trials ongoing to explore these patients. So the limitations right now are, first, it's unclear the FFR result. So I use a DCB, I know the FFR should be above 0.8, but if it's 0.81, we consider a good result, which is not what we do with the stents. With the stent, we should be above 0.9. But then if we reevaluate this patient for any reason, when should we reevaluate? Which should be the FFR at 3-month follow-up? So we have the experience with long disease LADs, when we have an FFR that is falling all along the vessel. There is not like a drop in one point, there is no one lesion. And there we can use long drug-coated balloons, and we will have a lot of dissection. And if we reevaluate these patients, because sometimes we are not comfortable with not reevaluating that, we do it 3 months apart, still TIMI flow 3, but still FFR 0.8. Do we leave it like that? So for me, that's a limitation, because there is not evidence-based decision. There is big key opinion leaders giving their opinion that this is safe, but honestly, we don't have enough evidence yet. So we need information for that, long lesions, and when to evaluate if necessary, and which should be the target result in physiology.
Thank you. So another question, but just to point this question is when use DAS after DCB? When you decide that it's not enough? You already almost discussed everything, but specifically, when do you do?
I think we probably over-indicate the use of stent after drug-coated balloon, because sometimes we don't like the result, and we are used to see very clear result of a stent implantation. So when we see the residual dissection, we tend to overtreat. But I think we should overtreat in any kind of situation when the flow is limited, it's impaired. If the flow of the artery is not correct, then we have to implant the stent. Unless, of course, it's a very distal disease, distal dissection, then we could even consider this as an investment procedure and reevaluate this patient, even with limited flow. We cannot stent up to the apex in an LAD. So if it's focal dissection with impaired flow, treat with a stent. If it's not, if it's impaired flow, but it goes to distal, I would not treat. I would wait for a few months.
So, and just another question from my side. If you have to plan the perfect study for DCB, which patient would you choose? How would you, what would you do?
In fact, we are going to start the trial, the Paris study. And it took me a lot of nights to answer this question. I could not answer it yet, but I have some questions. One is the physiology, as I told you. And the other one is the duration of the dual antiplatelet therapy. We see that this is very important, because in this study, we have a lot of bleedings in the stent group, 11%, I think, if I'm, not so much, but a very high rate. So this is important. So we say, okay, if we don't put a stent, we can reduce the dual antiplatelet therapy duration, or maybe not, because we have a dissection that is going to be there for several months. So maybe it should be longer, it should be 6 months, and with the stents, we can go with 1 or 3 months. This is something that we need to answer. So I think my question for the next trial should be high-risk bleeding patients, Is it better DCB or is it better GEs?
Thank you very much. So if the audience have other questions.
Hi, everybody. Hi, Stella. Hello. Very nice topic, very nice presentation. I just have a few questions. So my first thought when I saw the article, I was a little bit skeptical about the results because it's a little bit, in my opinion, it's a little bit too strong to consider DCB only treatment in multivessel patients, because I mean, I think there is a huge selection bias, as you mentioned before, because the real complexity of patients, I think it's what was responsible for the higher MACE rate. Of course, there is another MACE rate due to the metal that we implanted in the coronaries, but I still think that it's too strong to say that is comparable, the outcome for the population. So I totally agree with your considerations. And also for what is my current practice, I'm starting to think that probably DCB and DS should not be considered one or another, but complementary tools for different options. And actually, I understand when you said I've been thinking a lot about how to perform a study about DCB, because there are certain needs and how to answer the question. So this is my just opinion about the topic. So I totally agree with your considerations. My question is about more practical, because this morning I had a patient on my CAD lab that had this very long lesion of a very small diagonal branch. So it was a 2 millimeter vessel with at least 40 millimeter, and the patient suffered angina. I was very concerned about the idea of performing in general a PCI, because my thought was, if I have to perform a PCI, I would like to end up with a DCB, maybe a long DCB. And if I have a good result, okay, I did not implant a metal in this patient. But if I had to end up with a stent, that would be a 225, 38, I hope less, but probably a long DS. So in my opinion, I was very concerned about the decision. So my first idea was, okay, it's just a diagonal, it will not die because of that diagonal branch. So I started to optimize the medical therapy and see the patient on follow-up. But I would like to know also your opinion, when you perform a DCB, you have in your mind that might be the possibility for a bailout stent, or in that case, I'm very concerned about treating very small vessels with long lesions. What's your comment from your expert point of view?
Yeah. So thank you very much, Evelina. I think that first, as I said in the beginning, that this study showed a safety message. So for your patient, I think it's safe to use drug-coated balloon. It's as efficacy as a drug-eluting stents, probably, according to the study. We need more data. There is more efficacy than stents. That's a message they want to give. I don't agree with that message. We don't have enough data. But for safety and maybe avoiding the stent is good information. And regarding your patient, yes, almost in 1/3 of the patients, they use a stent and drug-coated balloon in the same patient. So probably was exactly your situation. So we can say from this trial, maybe you have a chance of 1 out of 3 that you might need a stent, according to the study. So it's a good decision. You have a stable ischemia. It's not a large territory, even if the ischemia test is positive. So I agree that maybe medical treatment is a good option. But if the patient remains stable, I don't agree that with medication we can leave the patient like this. If he's worried for that, if this impairing his quality of life, then we need to offer something. And drug-coated balloon is a very good option for the patient. So maybe 2 steps strategy: medical treatment. If the patient is very worried or the ischemia tests are very severe, then go for the drug-coated balloon. And unfortunately, 1 out of 3 chances of needing a stent.
Thank you.
Welcome.
So if anybody else has other questions, then we are a little, okay. So another question from the chat, 1 second, from Paolo. The question is about, so if you do a more accurate procedure with normal balloons, like DCB, the difference will be there will be so much difference between DCB and normal balloon. What do you think?
Oh, so this is the origin of PCI. This is why we started to test stains, because the recoil is very high, the restenosis rate is very high with conventional balloons. Even if we are very gentle, very adapted 1:1 to the vessel diameter, so the rate of new events in the future will be very high, much higher than with the stent. For this reason, it was invented the drug-coated balloon, and I think there is no discussion on that. There is a benefit from using drug-coated balloon in this scenario compared to conventional balloon. That discussion is past.
And just last question, do you feel confident to use DCB in STEMI? For example, if you have STEMI of a small marginal or diagonal, just a small vessel, and just using a drug coating balloon. I know that there are no data about that, but what do you think?
You mean culprit lesion or secondary
lesion?
So STEMI, I know what Colombo might say, but the fact is that STEMI are very thrombotic lesions, and if we just dilate, we might have a higher risk of poorer TIMI flow. In fact, very often when we pass the wire through the lesion and the artery opens, we don't predilate just to avoid this embolization of thrombi. So I would prefer a stent. But if the vessel is very, very small, maybe medical treatment is an option. And then if still the vessel is small but a long territory, as a third option, maybe a DCB could be a good alternative. From my point of view, this is absolutely empirical.
So thank you very much. It was a very nice discussion. Oh, sorry.
I have one. Thank you for the presentation and all the comments. One question, is the DCB family a unique family, or we have to consider the different balloons with different drugs? What's your opinion about that? So paclitaxel versus sirolimus are the same, or we have to consider as different device?
So we have to be very objective here, Marco. Paclitaxel has more evidence. That's the only thing I know. So the other ones with sirolimus have to create more evidence. When we have the evidence, maybe they are equivalent, maybe they are even better. In the stents, it's better, sirolimus, but we don't know yet in balloons.
Perfect. So we have this great discussion. Thank you very much, Professor Amat Santos, for your opinion and for all these precious comments. And thank you also to Juan Pablo for this great presentation. And we will see you in 2 weeks again with our journal club. So thank you very much.
Thank you, Rosella. Thank you, everybody.
Have a nice day.
Bye-bye.
Bye.